Changes are happening here at the ACR. Our new website is live, and along with it is a new membership model, redesigned with simplicity in mind. Streamlined with meaningful benefits for your career journey, our new membership model is not only for you individually, but also for your team of 4, 6, or even 15 rheumatology professionals. Learn more at rheumatology.org. ACR and ARP, where membership means excellence.
Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. As we explore the world of rheumatic diseases, we encounter a sobering truth. Not all patients have equal access to the care they need and deserve. The prevalence of healthcare disparities in rheumatology really casts a shadow on the promise of equitable healthcare for all. In today's episode, we've invited Dr. Irene Blanco for a candid conversation about the root causes of healthcare disparities specific to rheumatology, and we also examine their far-reaching consequences. We explore the impact on patient outcomes, the disparities faced by marginalized communities, and the urgent need for actionable solutions. From systemic biases that affect the diagnosis and treatment of patients to limited access to specialized care, we really tackle the multifaceted challenges that patients and healthcare providers confront in their battle against rheumatic diseases. Dr. Irene Blanco is professor in the Department of Medicine Rheumatology and is the co-director for the Clinical Research Ethics and Equity Consultative Service, part of Northwestern University's Clinical and Translational Sciences Institute. Her research interests focus on addressing healthcare disparities and adverse social determinants of health in rheumatology, and she is also an advocate for improving the diversification of the medical workforce. Hope you enjoy this conversation. Irene, welcome to the show.
Hi, thanks so much for having me, John.
So at what point in your training did you become interested in the topic of healthcare disparities?
I think I always had a sense of them growing up. I didn't come from a wealthy family. My parents were immigrants. My dad worked in a factory. So I think I had a bit of a sense of them, but I don't think it was until I was really volunteering during college. I went to school at Columbia, and in those days, there's literally a hospital that's right down the street that's now a Mount Sinai hospital, but at that time it was affiliated with Columbia. And so volunteering there, you really got to see the disparate care that certain populations face. And then subsequently, I did medical school at Albert Einstein College of Medicine up in the Bronx, which is where I stayed on as faculty for many years. And really in the Bronx, which has one of the poorest urban districts in the country, that you're really faced by, the lack of access and care that certain populations face. And that's where I think it really galvanized me to really think about these issues and think about, how do we address them in medicine?
And I know, over the years, you've been very successful in sort of addressing topics in healthcare disparities. And how do you tell people about what healthcare disparities are?
So I think a classic, maybe misunderstanding of healthcare disparities are, for example, differences amongst populations. So, it's a little bit of an absurd example, but I think if you think about it, way out into the differences, sort of, rates of breast cancer, for example, between like cisgendered men versus cisgendered women, right? There's going to be an enormous difference, and that's very biologically based, et cetera. But when we talk about healthcare disparities, really, we're thinking about the preventable, and this is a CDC definition that I like to use, the preventable differences in the opportunity to achieve ultimate and the highest level of health between socially advantaged and disadvantaged groups, right? So what we're really talking about is the lack of opportunity to reach optimal health in disadvantaged marginalized groups, which has different causes and different solutions than, for example, something that's like solely genetically and biologically based.
So those disparities, are they between the sexes, between socioeconomic status, between, what we call race or ethnicity? Where do you see the disparities?
Everywhere. Yeah, like, yes, yes, between all the groups. Yes.
And
If you think,
Mhm.
for example, how, right, when sildenafil came out on the market, how easy it was to get for erectile dysfunction, but not for pulmonary hypertension and, in digital infarcts, right? For systemic sclerosis, right? That you can argue was a massive gender disparity. Think about the lack of Medicaid expansion, right? And what that does for poor communities in certain states. When you think about what Medicaid and Medicare cover, right? In terms of private insurance. So this goes to race, ethnicity, gender, age, access, rural versus urban, right? The paucity of rheumatology services and rheumatologists in more rural states, right? If you think Liz Ferrucci literally gets on a plane and flies out to rural communities in Alaska because otherwise, and she was a pioneer of telehealth long before us because there's just such a paucity of rheumatologists. So, you can think about ways that people are marginalized. And because of their marginalization, oftentimes they're excluded from the systems that will allow for access to care.
Yeah, and it sounds like from what you're saying that there may be a lot of barriers to that optimal health that people should obtain if not for these disparities. So, for instance, bringing it down to the clinic,
Mm-hmm.
when we're seeing patients in rheumatology, what barriers do you think there are in the clinic setting that can contribute to healthcare disparities, specifically in rheumatology?
Access is enormous, right?
Hmm.
There's just not enough of us, frankly. Location, right? Urban versus rural versus suburban, right? Because even within urban centers, we may be localized at a academic institution as opposed to some of the more smaller community hospitals, for example. And so in bigger cities, it may be hard to get to that actual academic center. And that academic center may just not have availability to take on more patients.
Yep.
You can think about, insurance, right? Prior auths, what limits access to patients, what's on an individual Medicaid formulary that differs very much across states. So when I was in New York, Medicaid pretty much paid for every biologic I could ever want. And it
Hmm.
really wasn't that hard to get prior authorization. Now, I'm from Jersey and I lived in New Jersey. Medicaid in New Jersey was the exact opposite, that made it next to impossible to get anything that you wanted for patients, right?
Interesting.
So when you have to sort of see literally, one side of the river versus the other side of the river, you can start seeing how certain patients have access to certain content, even just translation, right? Translation services, even it's a mandate, it's a federal mandate to be able to offer translational services. Smaller practices don't necessarily do that or depend on family members, which is not the ideal way of translating, or potentially staff that speak a broken version of whatever language that they're translating because they're not trained medical translators, right? So, I think that there's multiple issues that impact an individual clinical encounter that can subsequently lead to problems downstream.
And tell me about sort of bias and the role that the clinician has in perhaps unexpectedly propagating these disparities. And, we've been, drilling into our heads, over the past couple of years about unconscious bias. And I wonder, to what extent does that also play a role in perpetuating some of these healthcare disparities?
I mean, I think it can play a large role, right? And I think that it's the discussions and I think the mindfulness of providers, or at least places where I tend to work, definitely, I think, has made us a little bit more mindful on patients' potential lived experience, right? So, I think that if a patient missed many appointments before, it'd be like, oh, they're so not adherent, they never come to the clinic, etc. Whereas I'm hoping, or at least I'm seeing, again, where I tend to work, providers being a little bit more mindful to say, hey, let's find out why, right? Let's find out why this person's not coming. How do we help them? How do we, see if we have resources to make it available? And now with telehealth, we could potentially do that, right? If we have a person that works a job that, works an hourly wage, for example, that doesn't necessarily get time off to go to the office to be seen, and it's just a quick, hi and bye for a biologic, and they don't necessarily need a physical exam, especially if they're doing really well, well, then maybe they can take that 15 minutes to do their telehealth visit in the break room, right? As opposed to coming to the office, right? Us not rolling our eyes when, the patient potentially maybe needs a letter to prove to work, right? That they were actually at the office. We have jobs that potentially give us that flexibility. Many people do not, right? Or thinking about, the access to just get to our clinics. Alan Anandaraja at U of Rochester, he created this program called IQ Lupus, and it's a multidisciplinary model, a care model for lupus patients. And one of the first things that he did was realize that, patients couldn't get across Rochester to come see them at the university hospital, right? So he moved the clinic to where the patients actually were. And then all of a sudden,
Amazing.
people can now make their appointments, right? So if we start to really, kind of not assume, our bias is to assume, well, if they really want to come, they're going to come, right? Well, no, that's just not going to happen. I think we need to kind of take a step back and really think about where our biases are coming into play and, make those interventions. So I think while it's important to acknowledge our biases and that biases may exist, that's literally step one. Step two is, once you know better, you need to do better, right? So if you see that there may be a bias that's leading to a poor outcome, well, then we need to fix said bias, right? It's not only about being aware of it, it's then subsequently addressing it.
Yeah. And certainly many of our rheumatic diseases seem to be more common, more prevalent, more severe in some marginalized groups. We always think about lupus as sort of one of those diseases where, people of marginalized groups seem to have worse disease than, for example, white women with lupus. How do you begin to untangle that? Because I'm sure it's not just one factor that contributes to some of those disparities. How do you think about some of those differences, within lupus in specific?
I think so many things interplay in lupus. I think that because it's a disease that disproportionately affects young women, and many of the manifestations are not outwardly physical. Frankly, there's a bias against women and sort of their pain, their symptomatology. It's in your head. It's hysteria. It's your period. It's whatever, right? That unfortunately a lot of things go unrecognized for a very long time. And it's not until you get florid rashes, frank alopecia, etc., that oftentimes you'll start to find things, right? For example, patients fever, malaise, achiness, etc., go to the ER. UA keeps coming back as a quote unquote dirty UA, when in reality it's lupus nephritis. She gets sent out 6 times. Then on the 7th, she's in massive renal failure, anasarchic, etc. Oh, that's when we figure out this is lupus, right? And so we know that there's a massive delay in care because it's under-recognized, but also because, we don't necessarily think that young people can get as ill as they can when, they can have chronic diseases. So it's maybe not necessarily on people's radar. But then if you don't have health insurance, you may not go to the doctor, right? If you don't have a ride, you may not necessarily be able to get there. If you're a 15-year-old kid and your parents are at work and, there's literally nobody to take you, how do you even get there? And when you get there, are you getting to a place where they actually have the knowledge, expertise, and experience to be able to, treat your problem, for example? So I think it's very intertwined. And then if you add like insurance status, you add language, you add health literacy, it becomes, yes, it's an onion, and it can be incredibly overwhelming to try to peel back the layers. But I think if we went into medicine, right, to help people, really understanding their lived experience and sort of like, okay, well, let's try to figure out what the biggest barrier is and then, take that first step, right? Because, otherwise we're just never going to reach any sense of the outcomes that we want.
And what do we know about adverse childhood experiences and their role in contributing to autoimmune diseases or lupus in specific?
I mean, I think we're starting to, look more at the epigenetic phenomena that may come into lupus. And, adverse childhood experiences can definitely lead to epigenetic changes that potentially may trigger autoimmunity downstream, right? But what other epigenetic experiences, exposures, insults, for example, if you live in a high pollution area, if you live in an area with a lot of sun, if you live in an area that has been exposed to certain pesticides, etc., how do all of those things then come into play to be potentially either additive or multiplicative in terms of your risk for autoimmunity downstream? And I know that, there's certain investigators that are really thinking about this. Cristina Lanata has been talking about this a lot in sort of thinking about, well, what exposures can be potentially affecting, what genes are getting turned on and what genes are getting turned off, especially in something like lupus that is so multigenomic at baseline, right? It's not like there's just one gene that triggers everything. And how can potentially maybe it's really the epigenetics that may be influencing, why certain people present the way they do, why, certain people have higher risk than others. Because even in identical monozygotic twins, the risk is not 100% if one twin has lupus that the other one will, right? It's only about 50-50 that if one has lupus, the other one will, but they're monozygotic identical twins. Theoretically, it should be 100%. But it really isn't. So exposure has to have something to do with it.
And do you see sort of some of those similar healthcare disparities in lupus in other rheumatic diseases? Because we always think about lupus as sort of the disease where these healthcare disparities exist. But are they also seen in other rheumatic diseases that we may not be as aware of?
I think they are. We're fortunate to have the Lumina study in lupus that really, I think, shone such a bright light on health disparities in lupus. But when we look across the board, it's literally every disease. Every disease, every non-rheumatic disease as well, right? Mm-hmm. Whether it's cancer, cardiovascular risk factors, right? PAD, diabetes, rheumatoid arthritis, psoriatic arthritis. Our medicines are insanely expensive, right? So if we just think SCS alone, right? thinking about how much Humira costs, or at least used to cost until, the biosimilars for Humira comes out. It's really a access issue across the board. Now, if we start to feed in potentially other disease severity, for example, right? You're going to see worse disease severity and rheumatoid arthritis in patients that are often marginalized. Why? Because they don't have access, they don't have health insurance, they don't have the time to go to the doctor. They'll ignore symptoms until it's absolutely imperative that they get seen, because, you just can't, you have a lot going on, so you can't fit having a chronic illness on top of it.
Yeah. Yeah, I've read some studies that show that I think it was blacks in rheumatoid arthritis are more likely to be prescribed steroids, less likely to be on biologics to treat the rheumatoid arthritis. More, and more often present to the emergency department.
Exactly.
So,
And that's potentially a bias on our end too, right? Like,
absolutely.
did we even offer the biologic, right?
Yeah.
Did we just assume that they're not going to take it or they're not going to want it, because we have these misguided assumptions that, they're mistrustful of these medicines. And I think that's also comes with exposure to a population, right? If you're a physician that kind of comes in and comes out of a neighborhood, but you don't really get to know your patients and you don't really get to know the population, you don't necessarily build trust either, right? We used to do these community tours of the Bronx when I was the program director at Einstein. And it was so that the fellows, we are, for all intents and purposes, very akin to primary care in rheumatology, right?
Yep.
We're an outpatient specialty. We will oftentimes have patients for decades at a time, right? A lot of our diseases greatly impact quality of life, et cetera. So, and they are very complicated treatment regimens that need a lot of aggressive management and oversight, right? So it's not common that we can just, hand a patient a prescription, say, see you in a year, right? Oftentimes we'll need to see them at least every 6 months, if not at least every quarter, right? So if you don't get to know your patients and you don't get to know their communities, like, how can you see somebody every 3 months and yet not know their neighborhood, not know where they're shopping, not know where they live, just not know anything? And, for me, it was imperative for the fellows to sort of get a sense of who they were treating outside of the clinical encounter, right? To really kind of humanize the Bronx that has a lot of negative stereotypes about it, for them to really understand that people are people outside of these settings, right? They're people inside the clinical encounter as well. But, outside of the clinic, they're not patients. They're workers, mothers, fathers, siblings, aunts, uncles, lovers. Like, they live a whole rich, full life. And if you don't make an effort to be a part of that and to sort of like understand that, then that's where trust sort of erodes, because, patients are like, you don't know me, you don't know where I come from, you can't have an open, honest dialogue with your patients unless you know a little bit about them.
Yeah, I think that's such a great point. Where I also trained in New York at Sinai, and we had, tours, and I would spend a lot of time in Spanish Harlem, trying to know the community and see where they shop. Also, just seeing where they shop, right? We tell them, oh, you have to shop, fresh fruits and vegetables, and then you go to the bodega that's at the corner, and
Exactly.
they
And like,
have
good luck
very
finding
little of that,
fresh
all
fruit and
canned
vegetable.
foods. Right.
Exactly.
I absolutely agree with your point about how important it is to sort of, know where your patients live and where they're coming from, so that you can have a better understanding. And how, right, access, you mentioned access. Is there a bus that they can take that gets them, to the rheumatology clinic? Where is it located in relation to where they live? All of these things are hard to really understand without actually sort of walking those steps that the patients walk through every day. You mentioned a lot of issues, and I think when researchers try to, better understand taking care of patients, with rheumatic diseases or in general, I think one of the issues that comes up is that it's hard to include, the populations that are most affected by some of these diseases. I mean, recall at the beginning of the COVID-19 pandemic,
Mhm.
where marginalized groups were, affected much more commonly and severely than whites. And yet most of the COVID studies involved, people of white ethnic backgrounds,
Mhm.
or in lupus also, right?
Mhm.
Where, most of the patients with lupus are the marginalized minority groups. And yet in most lupus research studies, they represent the minority of people enrolled in these studies. So how can we begin to understand what is happening to our patients if they're not included in these research studies?
I, and I think, yes. So they need to be included. And I think that while there have been gross injustices that have happened, populations still do want to be a part of research. They want to be a part of the narrative and the dialogue. It's sort of like you can't have a study about us without us. Kind of, you'll hear that catchphrase a lot in terms of like community organizing around various health topics, etc. So, and oftentimes the communities will know what they need or what they want to address or what's the biggest barriers that they're facing. And so I think it's, again, there's multiple issues, right? So if you have a study that has a high prevalence and incidence in, for example, like Latino communities, and you have no research staff that speaks Spanish, and none of your consent forms are in Spanish, and you do absolutely no recruiting in Spanish, well, then guess what? You're not including anyone.
Right.
Right. I think that, so that's like level number one. You made it absolutely impossible to include these people in your study, right? And there has to be an intentionality there, actually, to really think about, well, if these are the patients that tend to do the worst, that have the highest incidence of prevalence of disease, how do we include them? And sometimes it means, speaking to the patients, right? So to use the lupus example, the lupus patient groups, lupus is a rare disease. It is not a common disease. For rheumatologists, I think we feel that it's very common, but it's not. It's actually quite rare. And yet lupus patient groups are such a mighty presence and are so active within individual communities as well as online, that there's multiple ways of doing partnerships. And so now where I am, for example, at Northwestern, our CTSA, so our Center for Clinical and Translational Science, it's called New Cats. So we have multiple ways of facilitating community partnerships,
Hmm.
right? Either through the Center for Community Health, we can convene what we call SHARPS panels, which is patients from the community, either with the disease or with experience of the disease, that can act as advisors to an investigator. Myself and my co-director, Dr. Seema Shah, she's actually a bioethicist and a lawyer. We actually run a consultative service focused on bioethics and equity. So investigators can come to us, for example, with either projects or ideas that they have to say, hey, how can we be more inclusive? How can we address equity? How can we really think about the populations and the diseases that we want to study in order to really be intentional on including those participants in trials? So, I think the onus has to really come to the investigators and to pharma to take those next steps. A lot of lupus patients get seen at community rheumatologists, right? Either small hospitals or community centers, and not the majority are not necessarily always seen at large academic health centers. But that's where the trials are, right? How do you make partnerships, or how do you bring the trial to that small community health center, right? There's, for example, very little research in lupus that's happening at the hospitals that are affiliated with the HBCU, medical schools, for
Hmm.
example, right? So, we need to start thinking about how we change this paradigm and how we become more intentional about addressing these issues systematically. I think oftentimes, I hear a lot of discussion of like, well, we have to teach the patients about clinical trials. Like, yes, we do. No, I mean, but like, yes, I think we do. But at the same time, you can teach the patients all you want, but if you don't facilitate them finding a clinical trial or being able to join a clinical trial, like you don't provide transportation, you don't provide, adequate payment for their time and services, you don't provide things in their language, you don't provide. So then, you can educate them all you want, but you still made it incredibly, exclusive for their participation.
Yeah. You've highlighted, a lot of that this is, a very complex field, um, and barriers that are prevalent, within the patient encounter and within healthcare systems. I wonder how if we could begin our guiding our discussion to solutions. So you just mentioned some solutions in terms of clinical research and partnering, with community-based groups, bringing the research trials to the community, certainly educating the patients about it and being very intentional. I wonder sort of if you could think about, things that rheumatologists can do to try to address some of these healthcare disparities, things that, maybe hospital systems need to do to reduce some of these healthcare disparities, and sort of, within the public health realm,
Mhm.
things that should be done to address this. And certainly, if you could think about DEI initiatives and where those belong and how those can either help or hinder some of this progress, that would be great.
I'm like,
So
oh,
so so it's a lot there. How about starting with the rheumatologist?
so I'm going to say something that potentially might be a little provocative,
Ooh, I love it.
but I think that is certainly something that we really need to think about, right? And think about how we may have been complicit in this situation, right? So, we need to not be okay with certain groups doing badly, right? Like that has to stop being okay. And we'll say, well, no, it's not that we're okay with it. I'm like, well, if you're not doing anything about it, if you're not talking about it, then you're okay with it, right? Because if you're not actively trying to find at least the most minimal solution to how you're potentially contributing to the problem, well, then you are complicit in the problem, right? If you see a problem and you ignore it and you walk away, so somebody else is going to figure it out. Well, it's too, I'm not going to cure poverty overnight. Nobody's going to say that one individual rheumatologist is going to cure poverty overnight. But if you're not taking like moments of introspection to say, what can I do better? Then potentially you're part of the problem, right? We're all part of the problem until we sort of jump in. So we need to stop being, because I feel like oftentimes in medical school lectures or, when we hear other talks and other forums, you'll hear sort of, Black, brown, and poor patients do worse. Click, next slide, right? Why? Let's break that down. Like, what are we doing? Like, it can't just be, click next slide. And so like jumping off from that, I think the biggest thing we need to do, even as individual providers, is just like understanding our own data, right? Like,
Mm.
who's the population that I actually take care of, right? What are the resources that population has? What insurances do I take or do I not take? Right? Like, what do potentially these formularies have at my disposal that I haven't really thought of for, patients that may be from like low income groups, right? If I'm part of a larger health system, do they have any resources to help these patients? So it's funny because, my experience coming from the Bronx, And I was lucky. Like by the time I left Montefiore, Montefiore had built up an amazing social safety net that was, yes, particularly geared towards primary care. But because of where at least our teaching clinics were located, at least those patients we can get access because we sat within that primary care system and we had access to, for example, food pantries. We had access to immigration clinics. We had access to, mental health and addiction clinics. We had access to everything. Again, by the time I left. So this was after 15 years of a lot of advocacy and work. So I'm not going to say that it happened overnight, right? And I'm not going to say that the faculty practice had the same access because it didn't, right? Because it was like, no, this is only for primary care, as if, Black, brown, and poor patients don't exist in the faculty practice. But that's a discussion for another time.
So for that, do we need to like collect and visualize the data?
I think we do. We need to understand our data, right? We need to understand, and we need to understand where we're doing well and where we're not doing well, right?
Yeah.
So, for example, I get to Northwestern, and I'm like, Northwestern has this great, center for the like understanding what's it called? It's like the education for the social determinants of health, and they're doing, there's the Center for Community Health out of Newcat. So I'm thinking that they're going to do tons of stuff. So I turn to my colleagues. I'm like, so. Like, what's the number for financial assistance? And they're all looking at me like, what? Huh? Like, I promise you, this institution has to have a financial assistance program. And then sure enough, right? So now, like, all of these patients are now getting referred to financial assistance.
Amazing.
Right? Where, it's just asking those questions, right? And so we just did our data dump and, I pulled all of the lupus patients for the past 3 years at Northwestern. How many hospital admissions have they had? How many ER visits? Do we have a group of very high utilizers that potentially we can target? What are their needs? What structures exist at Northwestern to potentially help them? I acknowledge that I have the benefits of an enormous multi-billion-dollar health system behind me. And it may be challenging for a small rheumatology practice to think about. But for example, if that small rheumatology practice exists within a community that speaks a particular language, thinking about, well, maybe I hire some staff that speak that language, right? The next time I'm looking for an MA, a nurse, and a receptionist, maybe I actually ensure that they speak the languages that are prevalent in the community where I'm practicing, right? Like those are little steps that you can take. But again, there has to be an intentionality behind it, right? A real mindfulness to be like, well, I know I'm not going to solve every part of this problem, but let me do the little bit that I can, right? Let me ensure that I'm speaking with the, medical liaisons from the pharma company. So I know what the patient assistance programs that are available to my patients are and how to ensure that my patients potentially may have access to them. Which of these patient assistance programs may take because not all of them may take undocumented patients, right? And then as you move forward, thinking about, the micro advocacy that you could do within your own practice, like you guys, we have to hire somebody that speaks in Chicago. It's not only Spanish, right? It's also Polish. It's also Vietnamese, right? Like you guys, we need to hire somebody that speaks X, Y, and Z language, right? And it's sort of moving up. Well, should we have our signs translated, right? Should we ensure that the phone tree is easily accessible to people that speak other languages? And you start kind of moving up from like the micro advocacy to then the macro advocacy, right? When we go on the hill and we start talking about, like pharmacy benefit reforms and prior authorizations and getting rid of the middleman, right? And addressing step-up therapy, it's all because of what we're seeing in the clinic, right? It's all because of what we're seeing in the clinic. So, you can be an enormous advocate on a one-on-one level or at a national level. I hope that people just want to kind of get things moving. There's so much burnout in medicine.
Yeah.
And there's so much burnout because you feel like you can't do anything, right? And it's the one time when you actually intervene and you get that patient, that one drug that sort of like turns everything around, you feel so good. The patient feels so good. And it's like the burnout just, it dials down a little, right? And I think, you feel like you can do something when you sort of take some steps, at least in the right direction.
And, let's talk about sort of the hospital. If you were CEO of a hospital, Irene Blanco, the new CEO of
Oh, God.
Northwestern Hospital, what steps would you begin to take to address some of these issues, not only, within your primary care clinic, within your rheumatology clinic, but within sort of your hospital system in general?
I think, and again, it goes down to understanding the data, right?
Mm.
And understanding how, for example, so I think it was Chris Richland actually that published this, maybe with Alan Anandaraja, that lupus patients tend to be very high utilizers in
Hmm.
medical systems overall, right? Especially young lupus patients, right? They're 18, they don't have a lot of social resources, they don't have a huge social network to navigate these very hard, complicated systems and diseases. And then all of a sudden, we give them a multisystemic chronic illness and we dump them onto a system with literally zero parachute. And of course, they're going to be coming to the hospital and the ER all the time because, they don't have backing. So understanding our data is huge. It's really interesting to me and frankly, a little disturbing that until very, very recently, the quality improvement discussions in health systems oftentimes did not address health disparities
Hmm.
and thinking about data from that lens. And
That's
I'm sorry,
interesting.
health disparities is a quality issue, right? Because one
Yeah.
group is getting less quality, right? Is getting poorer quality care. And, if you don't see it from that lens, then you're not analyzing it and you're not intervening from it. So again, we have to not be okay with part of our patients getting substandard care from us, right? And if you think about it like that and Medicare reimbursements and how soon many of our diseases are going to be anchored on quality targets, right? For example, like lipids in lupus patients and, time to DMARD in rheumatoid arthritis patients. Well, as a CEO, what is it costing the system? What is it costing us when, patients don't necessarily have this access? So, for example, Northwestern has this huge initiative now to build a multidisciplinary care facility within Bronzeville, which is a major community in the South Bronx, in South Chicago. I will still say the
Still in New
Bronx
York.
years. It's too many years. So in South Chicago, to really address the needs of that community. And again, bringing Northwestern into that community if they can't come to us downtown.
Yeah.
Right. It's very mindful. And to understand that, what? Those are patients that are coming to our system anyway, right? If we create care models that really support them, they're going to bring more patients with them. And then that's just going to build up my patient base and bring in new and diversified revenue streams to begin with. So it's not, when you invest in communities over time, you're going to reap the benefits. I think short term, it can look like, oh, we're spending all this money, we're spending all this money. It's like, but we're building infrastructure to ultimately then lead to better outcomes for patients, right? Sort of like
Yeah.
you think about the multidisciplinary care models for diabetes that are now standard of care. Why are we not moving in those directions for the rheumatic diseases that are also so multisystemic?
Yeah, I totally agree. What is the role of medical education in addressing some of these healthcare disparities? And I mean that, when we're training medical students, residents, fellows, how can we sort of leverage those opportunities to help address some of these disparities?
So I think we need to talk about them more, right? I think we need to, educate our teachers, because that's exactly where they're hearing things from. And actually, we just published a paper in Advances in Health Sciences Education. I'm sorry if I butchered the title. And it was talking about the medical student experience at Einstein's, because so this was a project that we started a few years back. And in really like the hidden curriculum that students and trainees often get, and see sort of, we teach them this idealized version of medicine in the classroom, but then we quote unquote teach them how things really work in the real world, right? In clinic and in the hospital. And what our students told us, it was a qualitative study. What our students told us is that they witness a lot of poor role modeling. They hear, their faculty, and they see their faculty do and say things that potentially are, at its mildest, rude, at its worst, outright racist and biased, right? And we need to sort of think about how, we're educating, what we're putting forth, and really giving our trainees the tools to say, you know what, this is how you can address health literacy, right? Within your patient encounters. This is how, you can be an advocate. This is how, really giving them a tangible toolkit to move forward, but also thinking about how we address our educators and potentially our ineffective, poor role model educators to say, you know what? We know you have a bias, but frankly, that's not one that aligns with this institution or this division. I think in medicine, we've put up with abusive personalities for too long.
Yeah.
And frankly, the Gen Zers are not having it. I don't know how much you work with medical students now, but in my last, I work a lot with the medical students at Northwestern, and I've been, I was very fortunate to have multiple medical student roles when I was at Einstein. And the new crop, they have no qualms about, reporting situations that they see, about, really calling out when, a faculty member is being very rude and misgendering a trans patient, for example. Like they know who they are, and they know why they're getting into medicine. And it's not, I know when I was in medical school, I don't think we were as forthcoming and as open and as, just demanding that, our professors do what's right.
Yeah.
And so it's very exciting. But again, it's that clash, and it's a clash that we're seeing nationally as well, right? Where, 3 years ago, there were all these mass protests, demanding racial equity. And now we're seeing a massive backlash. And I think we're seeing that in medicine as well. It's playing out in different ways. But, I think that in education, we need to really address these topics and think wholeheartedly, sort of like, why are we doing this? Why are we getting into medicine? If we're going to provide patient-centered care, what does that mean? And how do we support our trainees, but also our colleagues, into doing what's right, for the patients and for each other?
Yeah. And I want to finish with one question that there's probably a lot of meat in it, but I know that, you're very interested in sort of work for diversity.
Yeah.
For a lot of reasons. And I wonder how you see the recent Supreme Court decision regarding affirmative action and how that could have, a downplaying effect on, the medical students being, admitted to medical schools and, eventually those that we're recruiting into the rheumatology workforce.
Oh, so no, I mean, I have so much to say, and I know that we don't have that much time left, but to me, the affirmative action ruling was a real blow to the diversification of the workforce. And we know that, for example, Black patients that get their primary care in areas with more Black doctors, I think this was JAMA like 6 or 8 months ago, tend to have better outcomes. Black patients that tend to have Black primary care doctors, particularly Black male patients, tend to have better outcomes, right? And that's because, again, you potentially think or see things that you wouldn't necessarily think and see otherwise, because you just have a closer bond to said community. And then subsequently, those providers then bring different dialogues and different ideas into research, into the healthcare system. They think of different solutions, right, that you may not necessarily have thought of because they're from within the communities that we're serving, right? So if you start taking out those voices and making it so much harder, for these critical people to come into medicine, we're only going to make taking care of our patients so much more difficult, right? We're not going to be as creative in devising the solutions and interventions that we need. I think there's such a, and I will be very frank and honest. I have benefited from affirmative action, right? Like affirmative action led for me to be admitted to my prep school as a, Latin American daughter of immigrants and daughter of poor immigrants. Again, my parents were factory workers, and it was affirmative action that led me to go to like my fancy prep school, that led me to go to, my fancy college, that led me, right? So like, I get it. Cause I mean, it's funny in terms of in the discussion of affirmative action, there's this subset of people that are envisioned as to not being deserving of a certain portion of the pie. Where then you have this battle of, X, Y, and Z group can only battle for this tiny slice of the pie. When in reality, you're got to think, A, it's not a pie. And B, who's benefiting from that 90% of the pie, right? Like, how about we just open it all up and dismantle the entire system? But in terms of, medicine, I think when there are less Black men going into medicine now than in the 1970s, right? When, admissions into medical school for the most part is trapped at about like 10%, 10 to 20% nationally. And there are some medical schools that are doing a lot better than others. For example, my colleagues at UC Riverside and their mission, especially because of where they are in inland California, is to really diversify, to bring doctors into that part of California that serves a lot of the migrant farm workers, for example. They're doing a hell of a lot better than a lot of other medical schools. But I think, if we really only look at like grossly admissions at about like 10 to 20% of medical school classes being racial and ethnic minorities, that means 80% are not.
Yeah.
Right. And to then completely reduce that 20% to like 5, 1, like what's the goal? Like, then it seems to be purposefully exclusionary. And then we are going to really need to rethink the systems that, again, are going to help serve our patients, right? Because ultimately it's, how do we get the doctors that think, look, speak, are the voice for the patients, so that way we can come and devise the solutions that healthcare will need to take care of this very multicultural, multi-ethnic, multiracial society that we have, frankly.
Yeah, Irene, I think, over the last 50 minutes or so, you've brought up so many points, so many touch points at which, these healthcare disparities get propagated from, the patient encounter in the clinic to, things like where the clinic is located, the neighborhoods where people live, some of those lived experiences, the healthcare system, the insurance, and brought it all the way up to the Supreme Court decision. So this has been a really enlightening and, somewhat depressing, talk and discussion. But I think, you've also mentioned some highlights of potential things that we can all do to try to address, some of these disparities and hopefully, move this forward. So maybe, next time we speak, Irene, you'll be able to highlight, some of the progress that you've made and that, the healthcare system has made in trying to address some of these disparities.
Great. Well, yeah, there has been progress, and I think we're making, again, some systems do it better than others. So I don't want it to end completely on a down note, but I do think, more progress needs to be made. We just have to, start, right? The longest journeys start with the first step. So, just kind of say, what are the little things that I can do? And, once it starts getting to be critical mass, then potentially will really start to affect change, right? So, little by little, everyone rowing in the same direction can turn the boat, if you will.
I love it. As a past rower, I love that quote. Thank you, Irene, for your time, and thank you for all the hard work that you've done in this area, and I hope that you continue to do so in the future.
Thanks so much for having me, John.
Well, there you have it. Some sobering thoughts and hopefully a way forward to begin dismantling the barriers that stand in the way of accessible and quality care for all. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, Apple Podcast, on Spotify, and of course on your favorite podcast app. Until next time, keep knocking down those barriers, and of course, stay healthy.